All right, welcome to the show, Dr. Patel. I'm really excited to have you.
Thank you so much for having me. I'm so excited to talk to you about this topic. I know it's been on everyone's mind and a topic of lots of conversation and on social media and just kind of like all over wherever you look. Yeah.
Definitely, these medications have definitely created much of a stir recently, and they're for good reason. We'll talk about what that is, and we'll go into detail. But first, I want to go into a little bit about what got you into this field, what got you into the field of medicine, and then also I want to also touch on why you got interested in nutrition. Because for those of you who don't know, for those of you who are just listening, Dr. Patel and I got connected through Instagram, and she is also just very interested in nutrition. That's why we got connected is she was posting about nutrition and just really interested in the topic, asking me questions about some of the things that I was posting about. And I love to see, MDs and quote unquote conventional healthcare settings who are really, putting that emphasis on nutrition and lifestyle. So, can you give us a little bit of background as to what got you into the field of medicine and then nutrition as well?
Yeah, absolutely. So, I'm a physician and I guess it's really cliche to say this, but I actually did want to become a physician since I was younger, and not because my parents told me to or whatnot. My grandfather, he had founded this clinic or hospital in a village in India and was like really able to help a lot of individuals, and that was really inspiring to me. And when I started my journey in medicine, especially through training, I actually thought I wanted to be an oncologist. And if you're not familiar with that term, that's a cancer doctor, which is completely different from what I'm doing right now, and the opposite of what I'm doing right now. But as I went through training, I'm South Asian. I'm of Indian ancestry, and when I was completing my residency towards the end, I actually was diagnosed with prediabetes. I was 30 years old, and I remember just thinking, like, how could I be 30 and have prediabetes and also high cholesterol? And if truth be told, if I, had to look back and look at my entire training, there was never this emphasis on following a healthy lifestyle or, what does healthy nutrition or what does a healthful dietary pattern even look like? I remember being in training and thinking to myself, when one of my patients who just had a heart attack was being discharged from the hospital, and his one question to me was, "Hey doc, I just had a heart attack. So like what kind of diet should I follow?" And I literally looked at him. I didn't really even know what to say. I said that I will consult the dietitian, but there was at least some comfort I could have given him had I had the training or had some background knowledge, but it just wasn't emphasized in our training. We learned about diagnosing diseases and treating diseases, all the medications, like why diseases developed, but when we talked about prevention, it was hardly a focus of any of our lectures. And as time went on, I really discovered the field of obesity medicine. And again, I was never taught that obesity is a chronic disease. In all of my training, it was always kind of, just glossed over as like a risk factor for certain medical conditions. But when I dug in and actually attended some conferences and really started to understand like why this was happening, I just became just so incredibly fascinated. I have a neuroscience background. I have a formal degree in neuroscience, and I realized that there was just such a big component of neuroscience in our brain as far as energy regulation and body weight regulation. And so I decided to pursue board certification, and I currently direct an obesity medicine program at a major medical center here in the Bay Area in San Francisco. And it's really just transformed my career and my life. And it's been great connecting with Dr. Chavez as well. He's obviously a wonderful expert in nutrition, and it goes to show you that we really need to bring that back into the conversation of modern medicine, and not because doctors need to be the end all be all know all. We have nutrition professionals out there that can help us, and we really need to integrate this care. And I'm on the mission to really, do that even in my own practice. And especially for diseases like cardiometabolic diseases is a term maybe you're not familiar with, but that's the intersection of conditions like obesity, diabetes, heart disease, non-alcoholic fatty liver disease, which that name is now changed to something else. But there's this intersection between all of these disease processes, and the foundation of care is a healthy lifestyle, especially healthful nutrition. But that part of the conversation, unfortunately, is still lacking in our system, but it is starting to change slowly. So that is truly my passion and like why I do what I do.
Yeah,
Yeah,
I love to hear it, and that's uh, I came from the other side, and that's what got me into this space. Is exactly what you said. Is in my opinion, nutrition is the most underutilized form of medicine. Like it is a
absolutely.
form of medicine that is not utilized properly. There's not the right specialists. There's not the right support networks. There's not the right referral systems, and that is really what needs to be done in healthcare. Like that's the step in healthcare that is going to really help to improve care overall. If we can actually get there, because
Yeah.
obviously the incentives are not there in
Nope.
terms of people being, reimbursement, actually being able to reimburse nutrition, lifestyle services, those type of things. But nutrition, obviously, exercise as well, which is, in my opinion, just easier. That's where I think we
Mhm.
need more support. We need more, specialists in terms of, people being able to really provide that care when it comes to nutrition. And with exercise, you can kind of, and it's not that simple, of course, but with exercise, it's like just move more, just exercise more.
Yeah.
And if you do
Sit
that,
less,
that's,
move more. Yeah.
most of the benefits of exercise are going to come from the engaging in the movement, no matter what it is, as opposed to with nutrition. You really need the right guidance, because it's really easy to get pulled in the wrong directions. And you can do that with exercise. People can give you exercise
That,
programs that aren't as good as others, but you're still going to get benefit from moving when it comes to exercise.
yeah.
Whereas nutrition, if someone puts you on a carnivore diet, for example, you go online, you have high cholesterol, you're like, what do I do? And then you get into this low carb group that says, the best thing to improve your cholesterol levels is to cut out all of your plant foods and eat carnivore. And that can be a problem. Like that can kill you. Like that will
Absolutely.
take years off your life. And I know you can speak to that as a specialist in this field and a lipidologist, and all about the way that carnivore diet impacts LDL
Yes.
cholesterol levels and all of that. And that's where I think, when it comes to the healthcare system, we really need more support around nutrition. And that really is the key in the future, is really helping to build those systems in place, so that doctors, physicians don't have to be expected to be that person. Because as we were just talking about before we got on this podcast, it is impossible to keep up with the research on nutrition and on medications. And that's why, I get asked about this topic often. I've been asked to speak on this topic, to make podcasts, to answer stories on this topic, and I don't. And the reason I don't is because I am not an expert in medications, and that's why I wanted to bring Dr. Patel on today, is because she actually is, and she can speak more to that than I can.
Yeah, no, absolutely. I dream of a day that, we integrate all of this wonderful care that's missing into the health system. And yeah, I mean, doctors frankly don't have time to counsel appropriately on nutrition, nor I think is it, really something that we have to do because again, we have specialists, we have people that have spent years learning. But yeah, like and I will say one of the more common questions I also get on social media is regarding medications to treat for weight management, to treat obesity. And it's, there's a lot of great information out there and there's a lot of not so great information. So looking forward to our discussion and hopefully clarifying some of those misconceptions and
Yeah,
helping people understand and make an informed decision.
definitely, definitely. And I love that you ended it with that piece. And everyone who listens to this podcast knows that that's the way that I approach every topic. Is really, we're not trying to encourage you, or kind of move you in one direction or the other, just to give you the right information so that you can make an informed decision that makes the most sense for you. Because with everything, with medications, with nutrition, there's a lot of things to consider. And I get questions like, what do you think about these medications? And there's so much to consider that even
Hmm.
if I did have the expertise to answer that question, it just requires a more nuanced discussion, which is what we're going to have today. So let's go ahead and get into it, and let's start off with talking about what these medications are. So, like, what are
Yeah.
the names? I know everyone's heard of, like, Wegovy, and so let's
Hmm.
talk about what the brand names are. What these medications do. Let's start there, and then we'll go from there.
Yeah, before I start, I'm going to use brand names of medications, but I have no financial conflicts or disclosures with any pharmaceutical companies out there. I don't work for anyone or consult for anyone. It's just, I've purposely done that. I want to be as kind of clear and unbiased as possible. But, when you think about the medications for weight management or to treat the chronic disease of obesity, the way to think about it is that it's a tool in our toolbox, right? These medications are not a quick fix. They're not the end all be all. They're supposed to be used in conjunction with creating that health promoting lifestyle, working on our nutrition, working on our fitness, stress management, and sleep. These are all things that I talk to my patients about at every visit. And we use the medications as a tool to really help them with those efforts. And the other thing I always emphasize with everyone, even before I start medications, these are meant to be long-term medications. Just like if you come off of your blood pressure medications abruptly, your blood pressure can go up. And this is the same phenomena that we see in the majority of patients, that if they abruptly stop these medications, they can have a rebound as far as weight regain. Now, some may think that these medications are all brand new. We've only had medications for a few years, given how much popularity there's been around, Zepbound or Wegovy. These are both brand names that we once a week injectable medications. But in reality, we've been treating the chronic disease of obesity for many, many years, and we've actually had medications prior to the ones that you've heard about in the media. That are, we actually, like, Wegovy is not the first GLP-1 receptor agonist that was approved for weight management. It's actually Saxenda, and that was almost a decade ago. But we don't really talk about Saxenda, and you don't really kind of hear about it because you do have these other more efficacious medications that we're hearing about. We also have pill medications that we've been using that people take daily. So some people may not realize that, there's actually multiple options for treatment, but it's not just once a week injectable medications. Now that's what you're hearing all the hype about. So, when you talk about some of the I'm talking about the FDA approved medications for weight management. We actually also use certain medications off label because not everybody has insurance coverage. And, we really have to try to help our patients with the resources that are available to them. And so, but the FDA approved medications, when it comes to like the pill medications, actually include medications like orlistat, Qsymia, which is a combination pill of two medications called phentermine and topiramate. There's Contrave, which is Wellbutrin, and naltrexone. Phentermine actually was one of the first approved medications for weight management. It's over like 50 years, ago that we approved it for weight management, and we still actually use that medication to this day. There's also Saxenda, which is the one that I mentioned earlier. That's a daily GLP-1 receptor agonist medication. So that's opposed to what you see now in the media with Wegovy and Zepbound, which are Wegovy was approved in 2021. Zepbound got approved in 2023. So that one's the newest one that we've added to our armamentarium. And if you are it's confused sometimes when we use these terms interchangeably, but I need to make sure that people understand that Wegovy and Ozempic are the same medication. I know that there was a lot of like, Ozempic is a diabetes drug, and why are we using a diabetes drug for weight management? But the reality is that they're the same medication. They're just two different brand names. So Ozempic got approved for type 2 diabetes in 2017. And then Wegovy got approved in 2021 for the treatment of obesity. And the same thing with Mounjaro and Zepbound. So same exact medication, same exact dosing frequency. The Mounjaro was approved for type 2 diabetes and Zepbound was approved for weight management. And so, yeah, it's a
Quick
little
question.
confusing. Yeah, go
Just
ahead.
to clarify, because you've gone over a lot.
Yeah.
So
Well, we gone over a lot.
the
Yeah.
yeah, let's back up a little bit. So the weight loss medications, so the orlistat, that one works by basically blocking the
Yeah.
absorption of fat in our
In our
intestines
intestine,
and causing us to kind of poop out some of the calories that we
the
eat.
fat. Yeah.
So causes like loose stool and can slightly reduce our calorie,
Yeah. That
our
one we don't,
energy.
I'll be honest, don't use as much. So I
Yeah,
don't even actually like talk to patients about it,
yeah,
but it is one that people should be aware of that is technically approved. Yeah. But
yeah.
exactly.
And then
Yeah.
the others, all of the others are more, are they stimulants? All of the
Yeah.
other,
Good question. So we don't know exactly. So the medications for weight management primarily, besides orlistat, actually work in the brain.
okay,
And we don't know exactly how, Like for instance, in Qsimia, the phentermine, is an appetite suppressant, but it also works on different areas. Like it works on different areas in the brain. The hypothalamus, if you're not familiar, it's just a structure in our brain that really has some areas that are responsible for energy balance and regulation of body weight. And what we're really talking about when we say weight, I'm specifically referring to what's called adiposity. Adiposity is the medical term for body fat. And so that's what we're really talking about here. So they primarily work in the brain. We don't know exactly how they work, but there are, places in the brain that they work to help with appetite, decrease hunger. Contrave specifically, that's the naltrexone bupropion combination, again, also works in the brain, can really help individuals if they're having certain kind of strong cravings. But we also see improvement in cravings when you use medications like Wegovy or Zepbound. So we tend to use those if those are available. Same thing for, Wegovy, Saxenda, and Zepbound works in the brain. They do have what's called peripheral actions or actions elsewhere in the body. So if you can imagine, some of these medications also improve diabetes, right? Because they improve blood sugar control and help the pancreas be a little bit more efficient in insulin secretion. And so there's other actions. The other thing to realize about medications like Wegovy and Zepbound is that they're being studied for other kind of disease processes that are to look at improvements in certain outcomes that are independent of weight. So, we see recently with Wegovy, there's been, a reduction in heart disease risk in patients that have obesity and heart disease. There's been studies that have looked at the fatty liver disease that I was referring to earlier in patients with diabetes and chronic kidney disease. The Ozempic or semaglutide, which is again the generic for Ozempic and Wegovy, has been shown to reduce progression to dialysis. So, I mean, these are not just, I really want to clarify, these are not just like weight management medications. Like we are seeing other host of like effects and outcomes that are improving. But we commonly see that patients with obesity have some of these other conditions, and so there's a lot of potential benefit to be had in the appropriate patients. So that was a lot to cover in that, in that one little segment. So, but that's kind of a big overview of what the medications are.
So, you mentioned GLP1 agonist.
Mm-hmm.
What does that mean?
Yeah, so GLP-1 is a hormone that our body makes in response to eating. So whenever we ingest food, our body makes GLP-1. That's a hormone that's made in our small intestine.
It stands for glucagon-like.
Oh, glucagon-like peptide 1. Glucagon-like peptide 1. And it exerts some effects. It helps us with fullness, helps with blood sugar management. But the problem is in our own body, GLP-1 gets degraded pretty quickly, meaning it gets cleared away very quickly within a matter of minutes. And so it doesn't really have a long time to interact in our brain. Remember, I told you the brain is a really important regulator of energy balance and our adiposity, or I'm going to just kind of surrogate say body weight. And so it really doesn't have a lot of time to interact in our brain because it gets cleared away really fast. So pharmaceutical companies like Novo Nordisk have made long-acting GLP-1 agonists. So they work on the same receptors as our own GLP-1, but for way longer. The half-life of the GLP-1 agonist medication, like Wegovy, for instance, is actually a week, which is so much longer than the minutes that we have for our native or our own intrinsic GLP-1. So
Quickly,
way longer.
Half-life means how long it takes for our body to break down that medication from what you took in to half of what like half of that amount of dose. So normally when our body makes GLP-1, within a few minutes, our body will break down 50% of that. It'll continue to break it down. It'll be gone in a few minutes. When with these medications, the half-life is a week. So this GLP-1 stays in our system for a lot longer than the GLP-1 that we produce in our body. So how does our body produce this peptide? Like what causes our body to produce GLP-1, and what role does it play in hunger, satiety, weight management? Like what is it doing?
Yeah. So our body produces our own GLP-1 in response to eating. So when we eat something, a mixed meal, what happens is that, we eat and then nutrients get absorbed and our blood sugar rises. And GLP-1 causes what is, when it comes to blood sugar management, a dose-dependent insulin secretion. So insulin, again, is a really important hormone in our body. It actually helps us bring our blood sugar down. And so what the GLP-1 does is it makes sure that our insulin response is actually inappropriate to what the rise in blood sugar is. And so, that's one mechanism of action. Like I said, it's not really lasting long enough. I mean, yes, it does some signaling to the brain, but it's really not, it's not lasting long enough to maybe create some prolonged satiety or prolonged fullness and decrease in hunger. It's also important to understand, like what I alluded to earlier, is that there's actually GLP-1 receptors all over our body. So there's receptors in the heart, kidney, liver, blood vessels. I mean, it's really not just like in one specific area, not just our gut or our brain. And so whenever you take GLP-1 receptor agonist, that effect of what our GLP-1 does in our body is actually lasting a lot longer. And so you do have that, like the hypothalamus and other areas of the brain have GLP-1 receptors. And so what these medications do, they in general can help with hunger, appetite control, satiety, and cravings. And I will tell you that there are biological variations as far as like what people are experiencing. Some of my patients have really strong cravings and they're, constantly kind of thinking about food or thinking about specific foods and kind of going out of their way to seek them. Some of my patients will tell me, I just can never feel full. I come from a family of individuals where we just, we know that we should not eat this X amount of food because we've already had this amount of food already. Maybe it's their third serving. They know that they don't really like need it, but they do because they don't feel full. And so these medications, I mean, I've seen like people's lives transform because it really helps them control that the cravings. It helps them feel fuller so they don't have to eat as much. It helps their hunger decrease because the one thing people may have noticed, anyone that's been through a weight loss effort, as you lose weight, your body does start making it harder to lose additional weight. And unfortunately, you may develop a weight plateau and you actually might start feeling hungrier. And it's really hard to fight those biological drives. And so I always tell patients that these medications are leveling the playing field for you. It's really, truly fascinating, to see like people who are constantly, their lives revolve around food. And then they just come in and they're like, I don't have to think about food the way I did before. I don't have to consume, or I have to spend all of this energy, thinking about food, and I can focus on, creating healthier habits. And it's just like something, just like the light bulb like switches in their brain.
Yeah,
And
I've
it's
heard that
just
too.
very
Like
interesting.
the food noise goes away.
Yeah, the food
I,
noise, that's the term. Mhm.
yeah, I wanna back up, and then I have
Mhm.
a couple things I want to talk about though. So
Yeah.
I don't want to forget it. So the GLP-1, when you say that it can have an effect on the brain, so when we're creating it, it doesn't necessarily have that effect because it's broken down quickly. But when we take it as a medication, we found that it does have an effect. And is it what's going on there? Is it changing like neurotransmitters? Is it? Do we know what's going on there? Like, wait, what is it? What it actually is the compound doing in the brain?
Yeah, it's binding to different receptors in the brain, and changing like neurosignaling. So I think there's, a lot to still be learned about exactly what's happening. But it's prolonging the effects of what should be happening if your own native GLP-1 was doing that. And so it's working on everyone's like individual biology. So if there are if patients are having trouble with satiety because that's just their own biology, the kind of their genetic predisposition, it will work on the GLP-1 receptor to improve satiety. So it's not like I there's different areas, like I said, in the brain that the GLP-1 receptors act on, but it kind of that overall general theme of like it helps with hunger, satiety, appetite, and cravings, depending on what the individual is experiencing. Because I actually spend a lot of time when I first meet a patient and kind of understanding like, well, what are you feeling? Like, are you having trouble with fullness? Are you feeling hungry all the time? Are you having cravings? Are you, like, what are you eating and like, why are you eating? Are you eating because you're hungry? Are you eating out of boredom? Are you eating because of drives? So it really helps with some of those biological drives. Of course, there's other reasons that we eat. If we eat out of boredom or if we eat because we're stressed, like there's things that we have to work on there. But it's really helping those biological drives to eat or eat more than intended. And everyone's kind of different in like what they're experiencing. Like it's just very, very, very interesting
So
kind of talking to patients.
yeah,
Yeah.
that's the next point that I wanted to touch on is you mentioned if you come from a family of people who all have struggle with kind of shutting off that switch and stopping eating. Um, a lot of people will hear this and hear some of the stuff that you're saying, and they'll immediately assume, well, that's just bad habits. That's just bad
Hmm.
programming. Um, I was one of those people, honestly, like probably 15 years ago, even less than that. I definitely felt that way. And then I started consulting for a genetics company. And I did some consulting work in the genetics of obesity. And I read some of those papers, and it blew my mind. I was just like,
Hmm.
wow, there is like a neurobiological component of that's impacting people's drive to eat, desire to eat, ability to say no, ability to turn off when they start
Hmm.
eating, all of these different things. And I always thought it was willpower, and we hear this
Yeah.
all the time. We hear this, it's willpower, it's willpower. And I know that there's probably people listening to this who, as they're hearing you say this, they're thinking, that's just bad family habits. That's just, these people have just developed bad habits. And the reality is that we truly experience these feelings and these drives differently. And
Hmm.
we have to be able to realize that. Like, um, when you see someone and you're like, oh, they just don't have the willpower, their brain probably works differently than yours to the point where they experience. And one of the things that fascinated me was a lot of the genes that seem to be associated with obesity were the genes that were associated with like
Hmm.
the
In the
reward
brain.
from food and the
Yeah.
pleasure
Hmm.
that's derived from food. And it's like the people who experience more pleasure from food tend to have a higher body weight. And that makes complete sense. Like, and as I'm reading about this, I'm like, oh, I love food too. And that's
Yeah.
also like that's one of the reasons that I got into this field too, is because I just really enjoy eating. And I'm like, I need to be able to do this in a way that isn't harmful to my health. Is definitely one of the draws to nutrition for me. And so can you speak about that a little bit more in terms of
Hmm.
like the individual differences, and what's really
Yeah.
going on there, and why for some people obesity isn't a choice. Like we hear this, obesity is a choice. You know, people have heard this, people have probably said this before. Can you speak more to why that isn't necessarily the case?
Yeah, and some of those, genetic variations that we see in certain genes, like they impact hunger and satiety. Like they're actually loci from the brain, and it's very like um, just very interesting. I mean, the way I kind of explain it or the theory behind it is that when like thousands of years ago when our ancestors were not in the same environment that we were in, obviously we're in an environment that's very challenging. Dr. Chavez and I were talking about how it's like the healthier choice is not the easy choice in our current food environment, but many, 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 many years ago, um, it was thought that when our ancestors were either spending all this energy, getting food, whether it be, I'm using the word foraging like very simplistic, but foraging and searching for food, any like weight loss that they developed was like a threat to their survival, right? Because they like had weight loss or malnutrition, I should say, and then they couldn't, reproduce or propagate the species. They were basically screwed. And so their brain or has developed, they developed, I should say, mechanisms to quote unquote, and the word combat I'm going to use in quotations because or defend against weight loss because this is hotly debated. But yeah, basically to make it so if they started losing weight, that there would be mechanisms to combat that. And so we've unfortunately brought some of those drives, some of those predispositions, I should say, into this like very modern, totally the opposite of what, was happening like even 100 years ago, food environment. So you're taking a genetically and biologically predisposed individual and putting them into this food environment and you're saying, okay, go thrive, right? It's like putting a canary in the coal mine and saying, go live now. That's like super hard, right? When you have something that you're constantly having to fight against, thinking it's all your fault. But in reality, like there's true biology that's happening. And it's really tough because even I talk about kind of my experiences. Again, pre-diabetes, South Asian, strong cravings for sugar runs in my family. I'm pretty sure that, um, when my mom was pregnant with me, I somehow got rewired to have these biological urges. Um, and that happens. We know that our environment, especially when our moms are individuals are pregnant, there's epigenetic remodeling of what's happening to the baby. And sorry, I'm using really scientific terms, but that's the environmental influence on expression of genes. And then, you go out, you're born and you go out into this environment, you develop and you have exposures from, continued exposures from the environment. Genes are turning on and off. And it's just like, you know, this is again real biology that's happening, and it's truly, truly, truly fascinating. If I had to argue, I mean, there's a lot of arguments out there of like, we need to work on preventing obesity. And I agree with you. And that starts really early. In fact, that, helping individuals that are thinking about having children get healthy, not only for their kids, for themselves. I think that's where it really starts. And of course, intervening and helping children learn these habits early and really kind of understand like the role that food plays in health in a really healthy manner, not in an antagonistic or negative way that ruins them for the rest of their life. But um, it's just really interesting because I think that there's a lot of doctors out there that think that obesity is caused by a lack of willpower. And that's, to be honest with you, like a lot of that kind of the little tidbits of like obesity that I did learn about in training, it was actually like that messaging was coming across like people just need healthier habits. And if they had healthier habits, they wouldn't have obesity.
Yeah,
And
yeah.
yeah.
In truly, even in nutrition training, a lot of that we were getting a lot of that early on. Fortunately, I had a really good professor. His name was Dr. Glenn Gazer. He wrote a book called, I think it's called The Obesity Myth.
Hmm.
But he was great about giving us an alternative perspective. At that point, genes weren't like the genetics of all of this
Hmm.
wasn't really well mapped out. Um, Probably dating myself a little bit, but these things weren't well mapped out at that point. But
Hmm.
one of the things, and I was thinking about this as you were talking about it, that fascinated me that he kind of exposed us to was some of the studies on, during like, I think it was like the Irish potato famine, where
Hmm.
um, when kids who were basically in their mother's womb during that time who were exposed
Hmm.
to very, like,
Poor
low calorie
nutrition. Yeah.
intake ended up having very high rates of obesity after that.
Hmm.
And the theory was that because of the lack of food during gestation, that they, once they were kids, that they just had a really strong drive to find calories, because that, like you mentioned, that epigenetic remodeling, and that epigenetic remodeling means that you have your genes, and then your genes can kind of change the way that they express themselves based on the things that you expose yourselves, or we get exposed to, especially early in life. And some of these early life events can really change the way that our genes express themselves, to the point where you can have a genetic predisposition and then have other factors that make it even worse, like something that happens during pregnancy, and then something that happens during childhood. You get exposed to the wrong environments and gain a bunch of weight during childhood, and change your response to hunger and satiety due to various habits early in, or like exposures early in childhood. And all of these things can add up to lead someone to make it almost impossible for them to be able to really like regulate their weight. And
It's
it, it's
hard.
it's
Yeah.
hard sometimes for the average person to understand this. um but as someone, and for me, a lot of it is just, it's just taken a lot of training, and then also the experience of working with so many people at this point. I've worked with over 1,000 people in various group programs and things, and one-to-one. And I've seen multiple clients who have truly struggled with like really low calorie intakes and lots of movement, and they just cannot, their metabolism works a little bit differently, their drive to eat works a little bit differently, and they're constantly struggling. And when you see those those circumstances, and you know, that's where these weight loss medications can really fill a gap, as you said, as to be used as a tool in the toolbox. So let's talk a little bit more about who can benefit from the use
Hmm.
of them, and then I want to get into side effects a little bit more
Yeah.
before we close things out. So in terms of like who's a candidate, when does it make sense, when are you thinking about, you know, prescribing these medications?
Yeah, so the FDA has criteria that they use that insurance companies basically abide by. And so I know, again, controversy. I don't know how people feel about this, but I'm just going to say that the criteria are what the criteria are, and they are BMI based. That is what it is. And this is, again, because of insurance coverage and what that boils down to. So any individual with a BMI of 30 kilograms per meter square or greater, or an individual that has a BMI of 27 kilograms per meter squared, plus what's called an obesity related comorbidity. So that could be, diabetes or liver disease or, another condition, like it is a candidate for treatment. Now, that's just kind of a preliminary criteria. Like as a doctor, I have to go through a patient's medical history and really understand like, okay, what are their medical conditions? What are what's called the contraindications? These are situations where we not use the medication because the risks are greater than the potential benefits. And then, really having that risk versus benefits discussion, again, wanting everyone to understand that these are really meant to be long-term medications because, they're not something we just start for 3 months and just send you on your way after that and while stopping it. So again, really important to understand that. Um, you know, there's different side effect profiles for depending on which medication you're using. Some of the oral medications, if you have like, for instance, like Contrave, like if you have uncontrolled high blood pressure, you really don't want to use that. Same thing with Qsymia, if you have a history of cardiac disease or heart disease, or if you're having some sort of arrhythmia, which is an abnormal heart rhythm, we really don't want to use the medications in that situation. Specifically, Qsymia also, if you have kidney stones or glaucoma, like there's a lot of different contraindications to think about, which is why it's so important that you get the medications from somebody who has comfort in prescribing them and really going through those risk versus benefit discussions. Because right now you can see all of the interesting things that happen on the web, which we won't get into on this podcast, but lots of prescribing that's not the most kosher, I should say. So I'll kind of focus on some of the more efficacious medications or the ones you hear about in the news. So when we kind of switch to the once a week injectables, we're talking about Wegovy again and Zepbound. GI side effects are the most common. And, again, you want to understand somebody's history. Like, do they already have GI symptoms from another medical condition? How could this medication impact those GI symptoms that they're already having? Are they having nausea from something else? And nausea and constipation, I will say, are like the most common side effects in my patient population. Knock on wood, I haven't seen pancreatitis, which is another one that, kind of comes up in the conversation. Pancreatitis is inflammation of the pancreas that's in a medical emergency. So that's not something subtle. But I have not seen that. And there's been some reanalysis of some data that really we're not seeing that strong signal or risk of pancreatitis, but GI side effects are common. You do want to make sure that patients are counseled appropriately. You do want to make sure that patients are not just started on the medication and then they're like seen 6 months later and hope for the best. I do follow my patients pretty closely, especially when we're starting medications and going up on the dose gradually as they tolerate it. And I like to keep my patients on the lowest dose possible that they're responding to. Kind of going back to the biology piece of it though, I think something that's really also very interesting is there can be significant inter-individual variability in the response to medication. So you could have like two people that are doing the same exact thing and they're taking the medication, but one might actually have a more robust response than the other individual. And again, there's some genetic or biological factor there. I wish there was like a prediction model that I could use to say like, you're going to respond, like based on these factors, you'll respond with this degree of weight loss, but I don't have that. So significant inter-individual variability, very interesting. I think that, patients need to understand that this is, again, the lifestyle factors matter because I have patients that don't really, there's a subset of patients that don't have robust weight loss with the medications. Maybe it's something related to their biology. Maybe there's something lifestyle wise that we need to work on. We try to make sure that everything is teed up here, but they may not respond because of something in their biology that's preventing them, despite, trying to follow a health promoting dietary pattern that reduces the number of calories we're eating. They're managing their stress. Maybe they're having some sleep disruption that's making them hungrier. So you got to think of all these factors when patients aren't responding. But again, these are not magic medications where, everyone gets started and everyone's going to have this like amazing response. The majority of patients will have weight loss, right? It's just that we want to make sure it's done in a healthy way. We don't want people to lose, excess lean muscle. Of course, you've seen a lot of that kind of maybe out in the news or social media. When you lose weight, it's not just fat loss, you're also losing lean body mass. And, I definitely emphasize, adequate lean protein intake and resistance training and really trying to help patients find whatever works for them because we do want healthy weight loss. We don't want you to get frail as you lose weight, especially if you're older and have more medical conditions. So, lots of things to be thought about and discussed. And it really, if somebody is just kind of giving you a medication without talking to you about side effects or talking to you about even benefits or what to expect or who to contact if you're having problems, like that's a huge red flag for me. Huge red flag. And I know
Yes.
that's happening.
Yeah,
Yeah.
definitely. That is definitely happening. There's a lot of over prescribing,
Yeah.
from what I've seen, and not, as you mentioned, not closely monitoring, and not properly describing side effects. So, can we talk about those a little bit
Yeah.
more? Because I'm
Sure.
not really familiar with them.
Yeah.
I only know what I know from speaking to people on them, and uh, so you mentioned GI side effects. What are those, and like what's going on there?
Yeah. So there's nausea that can be experienced, especially tends to happen more in my patient population with like medications like Wegovy versus the
Mm,
Zepbound. There's actually GLP-1 receptors in an area called the area postrema, which is a part of our brain that I'm not going to call it the vomiting center, but that's like kind of the colloquial term for it.
mm,
And so the GLP-1 receptors, again, they're all over, right? So they're not just working on specific ones, they're working all over the place. And so it can stimulate those neurons. And so some patients can have, some pretty profound nausea, which is very interesting. But it's again very individual variability. There's patients that don't have any.
that's
So it's so
interesting.
yeah.
I want to ask more about that because
Yeah.
I personally, so I was talking to someone who was on a medication. I forget which one, but uh he said that he has terrible nausea, but that's what's
Yeah.
like helping him lose weight is because he can't eat.
Ugh,
and
yeah.
and I'm as
Yeah.
because I was out eating at a restaurant, and they're just him and his wife were both taking the medications, and they just shared one meal and kind of had like a little bit of chicken wings and French fries, and they only ate like a really tiny amount. I'm like, the amount of nutrient deficiencies that are gonna occur if you guys continue to eat this way. I didn't go into detail there. I was just like, oh, cool. But I'm I'm concerned about that piece of it. So the nausea piece, is it brain, or is it also like a GI issue? Because this
It can be a GI issue because it can slow gastric
slow
emptying.
gastric
And
emptying.
so,
Okay,
yeah.
that's what
So,
I thought. I wasn't
yeah.
sure though, because
There's
hey,
peripheral effects as well. Yeah.
okay,
Yeah.
this person said that if he ate too much, he would throw up, and he said that it happened to him multiple times. And I was just like, this doesn't sound very appealing, as he was
Yeah.
describing this, because he said that he was telling us about a time where he ate two slices of pizza, and he threw up after the second slice, like at the table, because he just like was so full immediately.
So that's the other thing. We do counsel patients that if they eat a meal that has,
Oh,
sorry, I
you're
think we might
good.
have, oh, can you hear me?
Yeah, you muted there for a second. Oh, you muted again. I'll cut this out. There you go. You're back.
Oh, there we go. Sorry. Okay. So can you hear me now?
Yep.
Okay. So there is something we counsel our patients on when they're eating a high Sorry. Somebody was calling me and I keep hitting end and it just like they keep calling me and I'm like, stop. Okay, sorry. So yes, we do counsel patients on, higher fat content meals because they could have kind of worsening nausea and vomiting. I think the thought is that it decrease like somehow there's like a decrease in like the ability for like lipase to ingest the fat. I don't know. It's very interesting. Because I looked this up and I was like, why is this happening? And sure, it could be, delayed gastric emptying because the fattier meal moves slower, but yeah, it is. So we do counsel patients on that. If they're going to have like a cheeseburger for their birthday or something, like you're probably not going to feel very good on it. But I want people to understand that like the way individuals lose weight is not because we don't want them to be so nauseous that they stop eating completely. Like that is not what we want happening. We want you to have, healthy nutrition. We want to have lots of fruits and veggies and lean protein and, all of, those health promoting foods. We don't want you to stop eating and because you're so nauseous. And if you're having those side effects, definitely reach out to whoever's prescribing your medication and talk to them. Do we need to go back on the dose? Do we need to change up injection sites? I will tell you anecdotally, my patients, when they switch their injection site, from their abdomen to like their arm, it somehow sometimes helps with their nausea. I can't explain it. I don't know why. This is just something anecdotally that I've seen. Do we need, to make other changes? What's your diet look like? Are you eating a lot of high fat foods that are exacerbating the nausea? Like, so there's things again that need to be discussed but it's not, you're just too nauseous to eat. And that's why the weight is coming off. Like that's a horrible way to lose weight, right? You're just too
Yeah.
nauseated to eat. Like, so yeah, that's a common side effect. And the constipation as well is a pretty common side effect. Not everyone experiences it, but if you do, it does tend to get better, or not better, it tends to get worse, excuse me, with escalation of dose. So as you go up on higher doses, I will tell you the nausea, if patients are having it, tends to get better over time. But again, lots of due diligence and dosing and dose escalation. Constipation, unfortunately, gets worse. And so that's something that we have to talk to our patients about, especially if they're on other medications that can constipate them. It can really add up. Vomiting, can happen. I don't want my patients to vomit. I always tell my patients if you're vomiting, like something's wrong, you need to let me know immediately. Diarrhea, not so much. I don't commonly see that in my patient population. Um, those are kind of like, yeah, the major side effects. Now, you kind of have seen, on maybe in the media that all these medications cause stomach paralysis and gastroparesis. And, again, that's why these medications have to be prescribed with due diligence and, by somebody who's comfortable prescribing them. If somebody has baseline what's called gastroparesis, we want to make sure that we have to understand like why are they having gastroparesis? Is it from diabetes? Is it from another condition? Could their, again, these medications are used for diabetes as well. Could making their diabetes better improve the gastroparesis potentially? Like these are all discussions that have to be had. And I do think that, whenever patients do have adverse side effects and they don't have the support to work through those side effects or talk to their doctor, it's so detrimental because, it could put their health at risk. And unfortunately, some of that is happening and it's really scary to see. I won't even get into compounded versions of the medication either, because that's a whole other
Yeah.
slew and conversation. Yeah.
Quick note on that.
Yeah.
Don't use
Yeah.
compounded
Don't
versions of the
use
medication.
compounded versions.
Don't go to a
Yeah.
compounded pharmacy. Don't buy off, not FDA approved versions of the medication.
Yeah.
You've already heard how careful you have to be with actually taking the FDA approved medication. So there's a lot to go into taking a medication. And as Dr. Patel has mentioned earlier on, like this is a tool in the toolbox. And I know you mentioned this. I unfortunately I don't feel like it's emphasized in most cases or in
Mm.
the majority of cases when people are prescribed these medications. I don't think they get the proper counseling on lifestyle and exercise and nutrition.
No, they get it from like a med spa that like just kind of handed them a prescription or they got it from a compounded version. I've had patients come to me and they're like, "Oh, I went to this med spa and I got a compounded version and can you tell me, how to dose it?" And I'm like, "I have absolutely no idea what you're taking. Like I cannot vouch for the safety of it. I can't vouch if it's going to work. Like there was a report recently published, I think, there's like an article that Eli Lilly, which is the pharmaceutical company that makes Zepbound, and Mounjaro, they found some contamination in some of the compounded versions of tirzepatide, which is a generic of that generic. I'm using generic in quotations because there is no generic for the medication, but this is what you're going to get if you go to a compounded pharmacy. They actually found contamination, and that's really scary, right? Because you're injecting it into your body, and it's
Yeah,
yeah.
yeah, and it's just we just have to be careful with these things. And people who listen to the show know, like I talk about this with supplements, and um,
Hmm.
it's not worth risking our health in some of these cases for things that you know may not have the benefits. It's not going to be a magic pill. Yes, it can help you lose weight. It can help reduce some of the things we talked about, the appetite,
Hmm.
the food noise, and can assist with eating less and help with weight loss. But at the end of the day, you're gonna have to take it forever. You want to take a compounded, pharmaceutical that you may not be able to get access to when that pharmacy shuts down, and you don't know what is in there, and you don't want to do that. And so if you're gonna do it, make sure that you get it through a doctor who's going to do their due diligence, who's going to ask you about potential contraindications and reasons why you shouldn't be taking it, who's going to counsel you on lifestyle, who's going to talk to you about your nutrition, who's going to talk to you about high fat meals like you've discussed, because
Hmm.
uh, it's a tool in the toolbox, and you can't rely on it as the only tool, because I think there's probably going to be some negative long term effects for a lot of people who are trying to do that. And I don't know, kind of your opinion on this. I kind of like to hear it. I know we're kind of coming up on time, but just a
No
few
worries.
minutes of, like, because personally, like that story I mentioned a second ago, I saw the same thing with like bariatric surgery when it got very popular. Uh, you know, 15 years ago when I first was into this field and seeing that. And it's like, people lose all this weight short term,
Hmm.
reduce diabetes risk, improve all their health out markers. And then 5 years later, they start to gain some of that weight back. 10 years later, they've gained a significant amount of that weight back,
Hmm.
but they're also experiencing nutritional deficiencies because uh, anecdotally, I've met a lot of people who, 10 years post, bariatric surgery, they didn't change their diet. They just ate a lot less. And so they were nutrient deficient for years, and their hair is falling out, and they have thyroid issues and other health problems due to just nutritional inadequacy, is what I would call it, over a long period of time. So, um, what is your thoughts there? Like, concerns about people kind of not following a healthy diet, not living a healthy lifestyle, taking these medications, eating less, and then what the long term potential ramifications for that will be? Because yes, there's going to be benefits, especially in the short term, in terms of weight loss and improvement in metabolic health and diabetes, blood sugar, all of that. But if people end up gaining weight, if they can't stay on the medication due to cost or
Yeah.
insurance coverage or whatever the case may be, like there could be other things that pop up later on. What can you speak on that a bit?
Yeah. So, absolutely. Well, I guess I should say back up and say the GLP-1 receptor class of medications that we've been using for almost 2 decades, especially to start off by treating diabetes. The first one was approved in 2005. So we do have, you know, longer term data on just this class of medications. Now, of course, we most recently started using the once a week injectable medications for weight management. Like I said, Saxenda, we've been using for over a decade. But yes, there are definitely, yeah, one of the things you mentioned, if you can't get the medication due to cost long term, then yes, there is a risk of regaining the weight back. But that's also why it's important to, and there's not that many of us out there, which sucks, working with somebody who is board certified in obesity medicine, because there's other options we could use. There's other things that we can do to help you maintain that weight loss, including lifestyle factors. Let me just like put that back in there, especially exercise. So yes, patients need to understand, like, look, that's the risk. If you can't take the medication, you do risk regaining weight. We also don't want you to just stop eating. I tell patients all the time, like, I don't want you to just stop eating. This is not, some patients have a really profound appetite suppressant. And I'm like, look, you may not feel very hungry right now, but I need you to make sure that like you're setting timers to remind yourself to drink water and also eat and not go all day without eating. Because I'll tell you this, like what invariably happens is that they may end up eating more later into the evening and just end up consuming more calories because they didn't eat enough during the day. So we're trying to eat regularly, making sure we're having lean protein, making sure that we're still getting all of those health promoting foods because we don't want you to, again, lose weight and then like also have deficiencies in certain nutrients because you had a very limited diet or you didn't eat enough protein. I don't want you to lose too much muscle. And kind of going back to what you were saying about bariatric surgery, like the paradigm is really shifting. You know, previously with bariatric surgery, patients would have surgery, they'd follow with their surgeon for a little while, and then they would get kind of turned to their own devices after that. But especially what we're doing is integrating that care. Like I've been following patients pre and post bariatric surgery. We're still making sure that they're, getting the nutrients appropriately. We're checking their nutritional labs, at the times that you're supposed to have at least, especially if you're like 5, 10 years out, yearly nutritional labs to make sure that you're not, iron deficient or vitamin D deficient, which is one of the most common, vitamin deficiencies out there. But that's not happening. I have patients come to me and they're like, yeah, I got bariatric surgery 15 years ago, but I'm like, do you follow with your surgeon still? And like the majority of patients say no. And then I'm checking their labs, making sure that they don't have iron deficiency and whatnot, even other nutrient deficiencies as well. And so, yeah, I mean, it's not just here's your medication, here's your surgery, see you later. These conversations, this care is longitudinal. I tell patients um, your health didn't deteriorate overnight and your health's not going to improve overnight either. So it's not a quick fix. And Rome wasn't built in a day. That's what I always tell patients. If any of my patients are listening, you've heard me say that Rome wasn't built in a day and neither is your health. So it is that longitudinal follow-up. It's that due diligence. It's making sure that like if patients are struggling, I'm like, hey, when did you last meet with a dietitian that I work with? She's really wonderful. Hey, let's do a little bit of logging to see what's going on. Like it's trial and error and making sure that we're thinking of all of the potential, you know, benefits and also risk and making sure that the benefits always outweigh the risk when we're talking about treatment, when we're talking about certain approaches to lifestyle. And we have to pivot. Like life is not linear. Like stress will happen, things will happen, bad things happen to good people, and it makes it harder to follow healthy lifestyles when that happen. And I always tell my patients, reach out. If crap is hitting the fan, like I want to know, like if there's a death in the family and you're really struggling, like, let's talk and see what we can do and help you. It's just, these are all tools and we can't really view them as silos. It's not either or. I think that's a really big rhetoric that you hear. It's like, no, you got a lifestyle harder, or it's just meds, but it's like, no, it's the combination of these things that matter.
Whatever's gonna help.
Yeah.
You know,
Yeah.
I always say at the end of the day, people ask me about things. I'm like, if it's gonna help, it doesn't matter. I don't care if it's, even if it's placebo. If it's going
Yeah.
and getting acupuncture and that makes you feel better, even though
Great.
in certain
Yeah.
circumstances it may not be an evidence-based approach. Like that's fine. Whatever is gonna help you, as long as it's not people preying on you.
Yeah. With it, yeah, as long as it's within reason.
As
I mean,
long as people aren't
yeah.
convincing you of things and preying on you, like we
Yeah.
consistently talk
Charging you
about. But
or charging you thousands of dollars. But if you feel better after, doing certain meditative practices, like great. As long as it's
yeah,
not harming you, like, and you're okay, like fine, go for it.
yep.
Yeah.
And that end part of your discussion of, I know people are listening and they're like, I wish I had a doctor like this
Oh
because
yeah.
because I know that's not the norm. And unfortunately, it's not. But there are improvements being made in healthcare throughout the system to where this is becoming more common, and there are new
Hmm.
models being put into place. And this is something that I get really excited about. And I'll bring one of my other physician friends on the podcast. We'll probably talk about this a little bit because there's like new models that are kind of popping
Hmm.
up that are allowing more integrated models of care, as you mentioned, which in my opinion that's really the solution. Like nothing, these medications, they're going to work, they're going to be great. They're probably going to fall off for some people who aren't going to be able to take them long term, who aren't going to do the right lifestyle things, And at the end of the day, it's really just our healthcare system isn't really set up, as we were talking about earlier, to provide that care and support around nutrition and lifestyle. And that's really where we need to get to, is really figuring out how to interject that model. And it's probably not going to be through insurance companies, unfortunately.
No, unfortunately
But
not. I mean, I just don't think that, insurance companies, they want to see hard data, right? They need to see like improvement in some health outcome. And that takes a lot of time and a lot of energy and effort and money to, really
to run those studies,
run
yeah.
those trials, right? And it's just, I feel like it's just work that people may not want to do or insurance companies may not want to do. And it's really unfortunate to see that. But, having understanding that the healthcare system is not going to be able to do everything, and healthcare systems should be open to partnering with individuals or companies that are, augmenting the care that they're already giving. So making it better, right? It's not meant to disrupt or replace everything, right? Everyone always comes in, they're like, we're going to disrupt healthcare. But I'm like, good luck. Like, it's just, it's a really big challenge. But if we can augment the care, like, for instance, I give the example of I had gestational diabetes, no surprise, when I was pregnant. And there's not a lot of, it's like, of course, I had a wonderful team of doctors and people taking care of me, but it's just really hard, when you're going through all that pregnancy symptoms and challenges to take care of yourself from a gestational diabetes standpoint. And wouldn't it be great if there was some ancillary support services to kind of help with that and really, I use the word holistically. It gets used like a lot in a really bad way in a lot of ways, but just really helping individuals from with 360 view of like supporting them emotionally, supporting them physically, making sure that there's ongoing troubleshooting of like, okay, this is what this person can eat based on these pregnancy symptoms that they're having and limitations they're having. I'll give you my example. I had horrible acid reflux. I think a lot of pregnant women do. And then you're expected to adhere to a certain dietary pattern when you can barely eat. Like, it's just really challenging. And so it would be great, to find those partners and individuals to really help augment the care that we're giving. I mean, it's desperately needed. And if you are looking for an evidence-based obesity medicine doctor, there's a search tool on the Obesity Action Coalition to kind of look to see who's board certified. Now, I will say it's not a perfect tool,
Yeah.
but it is a tool to get the conversation started and try to find out who is in your neighborhood or city that's practicing obesity medicine. We're always trying to connect patients all over the, patients are moving to another state. We're on these Facebook forums and we're like, hey, does anybody have room in their practice to take on this patient? But it's so far from perfect. Like, it's not a good solution long
Yeah,
term.
yeah.
Yeah.
Unfortunately, there isn't any great solutions, and that's why we have to do things like this podcast, to really
Yeah.
help people to make their best informed decisions on their own and find the care that's going to be most appropriate for them. And in my opinion, in most cases, that's really good conventional medical care, and then a nutritionist who is really good.
Yeah.
Like,
Yeah.
I don't
Really
think
good
there's
one.
anything more valuable for long-term health than having someone who can help you with nutrition, and then also has a bit of an understanding on the other lifestyle things, like we talked about
Physical
earlier, the
activity.
exercise and
Yeah.
stuff matters,
Stress.
sleep and all that matters,
Hmm.
but nutrition is just the most difficult to just
Yep.
dial
Absolutely.
in, get appropriate for you. It's just takes a little bit more technical knowledge for that. But I really appreciate this discussion. We've been going on for quite some time, and I think we covered, everything in terms of how the medications work, what they are, the probably some medications that people didn't expect to hear anything about today, side effects, and also I think really refreshing to hear you talk about this integrated model of care. I think that everyone, myself included, and all the physicians that I network with and bring on this podcast, all the oh, and all the physicians that I network with and bring on this podcast, all have that same vision and hope for the future of some
Yeah.
integrated model of care where we're all working together and really helping the patients get the best available care, and do what's really best for them. And hopefully we can help create something like that in the future.
Yeah,
Yeah.
absolutely.
So I'd
I
love
can't
to
wait to see
continue
what
to
you're
do
up
this
to,
with you.
Dr. Chavez.
Yeah,
Yeah.
definitely,
Yeah,
definitely. So I appreciate this discussion. Thank you for coming on. And can
absolutely.
you
Thanks
tell
so
everyone
much.
where they can follow you, and get more
Yeah.
information about where you practice, and kind of just keep up with what you have going on?
Yeah, so I am on Twitter and Instagram at Dr. Plantel. So I'm Dr. Patel. I love, eating plants. There's a lot of reasons to do that no matter what dietary pattern you're following. So it's a little play on my name. So yeah, feel free to reach out and any follow-up questions, happy to answer. But it was so great to have this discussion. And thank you so much for having me today.
Yeah, thank you so much.
Yeah,
I will link that in the show notes, and I appreciate you for coming on.
awesome. Thanks.
All right, bye.
Bye.
Awesome. That
Oh
was
yeah.
good.